Hi, this is a trauma case in a young patient who had blunt trauma resulting in capsular rupture, anti-capsular rupture, vitreous in the antechamber, as well as some displaced part of the lens matter in the vitreous, as we can see on the B scan. This patient does not have insurance, so he has very limited access to healthcare services. This is the start of the case. We're staining with trypan blue to look at the capsular defect, followed by canalogue staining to see the vitreous. We identify a big anti-capsular defect inferiorly, as well as a sheet of vitreous prolapsing in the anterior chamber. Using the vitreous cutter, we remove the prolapsed anterior vitreous from the antechamber, taking care not to damage the remaining capsule. With this achieved, now we switch the cutter off and use it to remove the lens material. We're pulling radially, try to remove the lens matter without damaging the remaining capsule or zonules. Now viscoelastic is placed in the antechamber and the instruments are placed to the other side. In a case like this, it's very important to remove all the lens matter so as not to have significant postoperative inflammation. To achieve this, another paracentesis is made to have more ergonomic access to the lens matter. Attention is now given to the posterior segment for parasplantar vitrectomy. This starts by posterior hyaloid separation, followed by removal of the vitreous at 360 degrees. Internal surge reveals retinal whitening as well as retinal holes from trauma. Because of the absence of an intact capsular bag, we decided to proceed with a posterior capsulorhexis to secure the lens. The capsule opening started with an MVR blade, followed by curvilinear posterior capsulorhexis using a curved forceps, then the utrata forceps. A 3-piece IOL is then placed in the sulcus and the optic is captured through the posterior capsulorhexis. Finally, cryo is applied to the retinal breaks. This is the end of the surgery and the lens appears well centered.